Hello, everyone. I'm Darla Winitsky, Vice President of Customer Success at Telcor. We're so glad you've joined us again as we continue our series and round out the discussion on RCM Gap Analysis for Laboratories, Visibility, Action, Revenue. Thank you for spending this next hour with us. Here's what we have planned for today. We're going to start with a quick recap of key highlights from session 1, then move into recommended tools you can put into practice right away, share practical tips, and call out some of the most common pitfalls to avoid, walk through a real-world laboratory case study and lessons learned, and finally, explore how to maintain governance and sustainability of your gap analysis process for long-term success. As always, we'll wrap up with a Q&A session, so feel free to jot down those questions as we go, and we will be sure to address them at the end. At this time, it's my honor to introduce Sandra Pearson. I've had the privilege of working with Sandra in a variety of capacities at industry events, and I'm thrilled that she'll also be presenting at Telcor's upcoming National User Conference. Given the growing importance of performing an RCM gap analysis, we knew Sandra's expertise would be especially valuable to share with a broader audience through today's webinar. So with that, Sandra, welcome. It's a pleasure to collaborate with you again today.
Thank you, Darla. It's my pleasure to be here, and thank you everyone for joining us this afternoon or this morning. On Tuesday, we talked about a gap analysis and what is it and what are the processes. So we basically do a gap analysis so that we can look for areas of improvement. First thing we do is we set our objectives, such as we need to decrease denials, or we're getting too many adjustments on our EOBs from a certain payer, and we're not sure why. Map what your current state is, what are your current processes, define what your specific target is, and then you get to work at the root cause analysis. And that root cause analysis, we want to set our goals. We want to use our SMART goals, right? So that we're kind of keeping it simple. We're making sure that it's measurable, and that it's actionable, right? And to look at the steps that we can do to improve efficiencies, which hopefully will also result in improved revenue and compliance. Once we've done that, we then measure, we execute, and then we measure. Usually 3 to 6 months after execution is a good time to measure improvement. If for some reason you see at that point that you're not having improvement, it's a good time to go back to the table and reanalyze things to see if there was something that you missed. But if you're showing improvement, definitely make those graphs and charts so that you can share that information with your whole, not only revenue cycle management team, but your leadership and the rest of your organization. Because as we spoke about on Tuesday, revenue cycle management starts way before anything gets to the billing team, right? It starts with that ordering clinician, because if that ordering clinician doesn't send you the information, doesn't complete the TRF, in the appropriate way, then you don't really have anything to work with, right? If your upfront teams aren't ensuring that you get prior authorizations done, that medical necessity is gathered, then it makes it almost impossible for you guys to do your job. All right.
Thanks, Sandra. And I kind of think of a test requisition form as though it's similar to a bill of sale if you're going to buy a car, right? So I'm out buying a car. If I don't do my due diligence and make sure that my car is in great shape, I might be getting a lemon, right? Well, if I don't do the due diligence with that requisition and make sure that all the information is provided, I might be getting a lemon and I might not get reimbursed for it. So something to think about.
Great analogy, Darla. Great analogy. We also talked about, as we've moved into the electronic age, how we can actually utilize electronic requisitions to support our medical necessity and support that those requisitions are completely completed by working with our IT department to have certain parts of that electronic requisition hard-coded. So you don't get to pass go. And like the little banker in Monopoly, you're not going to collect $200 if that information is not included. So let's move on to tools and analytics. So after we've done our gap analysis, what are some tools and analytics that we can use when we're looking at data, whether it's while we're doing a full spread analysis or if it's just on day-to-day basis? So claims tracing analysis. Claims tracing analysis is an interesting concept, and it's actually not only looking at what is done within your control, right? Within your purview of your lab, with the information that's collected, with the reporting that the lab does, and then with the generation of claims. But it's actually following that claim through the payer, right? Checking whether you're using your clearinghouse or you're using Availity or one of those systems, but monitor that claim as it moves. Sometimes what you'll find out is that your struggles are not anything that you've been doing in the lab. You could have a connectivity problem with the clearinghouse, right? And so you're giving the clearinghouse all the information, but it's not getting fed into the payers system appropriately. So you can follow that. You also, the other reason that you would want to do this is you kind of want to, for each payer, it's a good idea to have an idea of how fast they pay, right? And if you've got a different portfolio of tests, for instance, most of the time sequencing, next generation sequencing, those claims will often take longer to process through because of medical necessity, right? They always want to look and relook, even if you've done a prior authorization, they still want to look on the back end. Whereas if you're doing more reference lab testing, a lot of those will go through and pay if you've got clean claims within 14 to 30 days. So it's good to have that kind of a benchmark so that you can get an idea if suddenly your reference lab claims are taken 180 days, there's a problem. And you need to probably be on the phone with the payer to figure out what's going on, right? Likewise, with any of those more complex claims, if you're really going past 180, then I would say there's definitely a problem and you would need to be calling somebody at the payer to see, because if the payer then says, well, we never got it, right? And you've wasted all that time when it's really been a clearinghouse problem, that would be a bad day for everybody, right?
Right.
So
And the
what's
other
another?
thing is, sorry, the other thing is to kind of keep in mind that you want to make sure that you have a system, a solution that actually points out these are all the claims that are still outstanding with the payer. So unresponded claims, meaning I haven't received an 835 or any type of communication back. You want to have visibility to that information.
Absolutely, because without that, you could have claims dangling out there in the universe, right? That you don't even realize what's going on. So that's very good, Darla. Thank you. Data analytics for denials and prepayment trends. Again, your revenue cycle management system is your best friend, right? And working in automation and different tools within that system that'll help you analyze that data. Just like Darla referenced with, the claims that kind of haven't processed timely, where are those at? But looking at denials not only by payer, but by CPT code. You may think you have a payer problem at a high level, but it really could drill down into one particular CPT code within a panel, right? Within a test that you guys are performing very, very often. And payment trends. It's also good to, whether it's for forecasting or for just managing your book of business, to know what your payer trends are. For instance, understand and have built into your system the automation of all your contract terms so that within looking at the data in your system, if that payer is paying according to contract terms, right? If they're not, look at the denials. Look to see, are they reducing, are they adjusting that claim, or are they just flat not paying it appropriately. And if that's the situation, again, we talked about partnering with market access. If for some reason that payer is not paying continuously appropriately, that's a great time to be partnering with your market access person, because you can supply them with the data that they need to then take into the payer. And because every time I've ever taken anything to a payer, they say, give me examples. They don't believe you. They want examples to go look at. So if you've already provided that to your market access person, they could go in and say, look, we've got, you guys paid us great for the first 6 months of this contract. Now you're going back and you're treating us as if we were never in network again. What's happened? What dropped off? And here's some data for you to go check it out, and then that way you can get it worked and hopefully fixed. Compared to benchmarks. So there are some industry benchmarks that are out there. Medical Group Management Association has some general benchmarks that some folks use. I actually think that it's better to set your benchmark and to measure against that. Even if, I think we always need to look at what our goals are, right? We all need to have goals of where we want to be. We need to look at reality, though, when we do this gap analysis. Where are we really at? And then do that analysis, put in your plans of correction, measure them so that you can see and give feedback of how close you're reaching those goals, because we all need feedback, right? We all need it. And if it's that whatever we designed during our gap analysis process isn't working, we need to look at it, right? We need to get suggestions. Maybe we need to broaden our analysis to look at, more of the front end situation. Sometimes when folks in the RCM world do gap analysis, we just look at like really what's under our purview. And we forget that there's this whole world out there that happens before we ever get any of the information on the patient, much less the report from the lab. Right? And oftentimes information doesn't get mirrored up, right? So you could have your intake folks thinking, well, we scanned in all that medical necessity documentation, but there's a problem and it's not getting mirrored up so that you have access to it to be able to submit it. So definitely continue to look at those things.
Okay, this next one that's coming up. He's a biggie because, we've heard all kinds of things about AI and bots and those kinds of things and automation. So automation, pre-built edits, RPA, auto ERAs.
Yeah. Oh, wow. This one is $1 million one, isn't it, Darla? So in today's world, both on the lab side, what happens in the lab, as well as in the RCM world, just like everything else in the news, everybody wants to talk about AI, artificial intelligence. And I've learned to really zero in on with folks and say, well, what do you mean by artificial intelligence? Some people refer to an algorithm as artificial intelligence, right? Some people refer to automation as artificial intelligence. And then you have those diehard people that they really are talking about true machine learning artificial intelligence. In the RCM world, I think it's really important for us to differentiate that. Most systems that I'm aware of that are doing any kind of quote unquote AI, it truly is automation, right? It's where you're working in either your individually developed billing rules or the payer medical policy and the payer billing rules into your revenue cycle management system, so that you have that helper, right? You don't have to keep a million things. Your folks don't have to keep a million things in their head. Or I remember the day when we had the sticky notes everywhere, sticky notes all over our cubicle to try to remember, okay, the Blues do it this way. United does it this way. Do I need the Z code? Do I not need the Z code, right? Well, definitely if you don't have that automated, get with your partner, your revenue cycle management partner. And you notice I'm really careful to say partner. I hate the word vendor because in my opinion, your folks that you're working with, whether it's with the software, with the system, or it's with a partner that's doing prior auths for you, or it's your clearinghouse, you need to be partners. You've got to be working together. You're all on one team, even though you might work, theoretically for other people. And I think if you team with people, you have a much better relationship. But sit down with them, especially if you've inherited a system from someone else. Sit down, figure out what are the rules that have been automated, right? Find out, most of the systems will come along with logic for like NCCI edits and those modifiers, when's a modifier appropriate, which modifier can be used with this code or whatever. But there's so many other things that are individual by payer and even individual by lab that you can have automated that will not only make your life much easier, but it will help you when you're developing your KPIs and your benchmark reports, your dashboards. Because then you know what's automated, what you can measure against.
Sandra, I have to tell you that the sticky note comment made me smile, because I remember in my implementation days when I would walk into a customer site and I'd say, okay, give me all those sticky notes because we're going to build those rules into the application. I don't want to see sticky notes at everybody's desk. So
I have to tell you, Darla,
that.
those of us that have been around for a long time, it's hard for us to give our sticky notes up. I still have sticky notes today over here.
I love it.
We want our paper. All right, tips and tricks. I think my favorite tip and trick is cross-functional revenue cycle management committee for oversight. I think, I don't care what you're doing in life, you need fresh eyes to come in and ask some questions sometimes. Folks that don't do what we do every day see things differently, and they have questions that we wouldn't even think about, or they spot something in the data that we've looked at that data so many times that we just don't see it anymore, And so I think by having cross-functional teams, it's good for that reason. I think it's also good so that your whole organization understands that revenue cycle management is not just billing and collections. It is an organizational process that everybody has skin in the game for. I worked for a lab, and we were bought and sold many, many times during the 13 years that I was there. And one of the times, and we kind of knew this was the end of the road for us because we were sold to a venture capitalist group, and we kind of all know what that means. We were sold because we were in the red, big time in the red in every area. And so what we did is we did a cross-functional team, and we had a representative from every single department. And we did a 6-week process where we would get together an hour and we would learn everybody else's process, with data that went into a claim. From what did sales educate? What did customer service educate? What did intake gather? What happened through accessioning? All the way through to the end. And what we realized is we had this really great project manager who was great with spreadsheets, and we overlaid the flowcharts. And we realized we had so many inefficiencies. We were duplicating efforts in many ways, and other things that we thought were being done by other departments were never being done. So that was very insightful for me. And we had been begging because we understood the value of prior authorization. We knew that if we didn't get it, that appealing retrospectively was getting tougher. And we had been begging to have someone either trained in intake and accessioning, or someone from our department moved in there to take on that role, so that if there wasn't a prior authorization, it could be initiated before the testing started, because that is crucially important, right? Doing this activity, that was one of the things that we implemented as process improvement. And within 6 months, we were in the green again, because we had folks that were bought into really making things better. So I probably have preached a little too much about it, but I'm just super passionate about it.
I am too, and I love this as the first bullet on this slide because you're absolutely right. You know, a lot of times we have the individuals that are actually in the lab doing the work, right? And they're not realizing that if they miss something through that requisition accessioning process, that impacts the downstream effects, right? And same thing with the
Absolutely.
sales team. So if our sales team isn't aware that we're getting these rejections or denials because of something that's happening with the client, if we don't have that communication thread happening, it's just going to keep perpetuating, right? So I like
Exactly.
that one.
Exactly. Exactly. The second is automation. If you're not using automation, then look at when you're doing your gap analysis, what are the areas where you think you're having the biggest difficulty? So, denial management may be that. And work with your RCM partner to have automation built into that. So that number one, you can monitor and manage so that your person that maybe is doing the blues isn't just getting all the blues data dumped into their queue and they're having to go through and figure out, okay, what's this denial, what is this, those kinds of things. Or I've even worked with labs where nobody even looks at the denials, they never look at the EOBs, they just what I call churn and burn. They just bill the same thing over again and over again and over again. And I think that that's a futile effort on both your part and on the payer's part. I think it dilutes any profit that you have because administratively that takes time and money to do that, right? So that's my recommendation about automation. Get
Yeah,
comfortable with it.
and my comment on this one is to make sure that you're looking at employee productivity, right? Because it may not necessarily be a specific denial that you're having an issue with. It may be that we need to do additional training for an employee or might need to write some different policies or procedures around a process that's happening that to streamline things a little bit better for that back end team.
Great call out, Darla. That is really good. Absolutely. And especially if you're inheriting, right? If you're new to an organization and you're inheriting someone else's processes, to find out what those are because you may come from a different perspective and see gaps in it from the get-go. There's not a problem with that. The third one, establish not only KPIs for your whole book of business, but also staff KPI dashboards. Because again, I think individuals, most of us do like accountability. We may not like the feedback, but we do like to know really how we're doing. I have to give you my best example. I actually started using this app to track macros because I had 5 pounds I could not get off, and I kept saying, I'm not eating, I'm not eating, I don't eat, I don't eat, I don't eat all day. And when I started using that app, and I realized, oh, that piece of candy has 300 calories in it. Oh, that Starbucks that I just drank is another 750 calories. You know, I had no idea. I was astounded. I think we do the same thing at work, right? Especially if we're in a job where we feel like it is monotonous a little bit, you're doing the same thing over and over and over again. Um, I think we kind of forget. It's not that people deliberately don't do things. I think they get overwhelmed. It's easy to get overwhelmed today. We're always dealing with a staffing shortage. And I think that it's a good thing to have that feedback and have benchmarks. It's also good for when you do reviews, right, with your employees to be able to use that as an example. And then if they're having problems, discuss what might be causing those.
Yeah, and this is another one that I love this one because People tell me I'm a competitive person. I don't think I'm competitive. I'm competitive with myself. But when it comes to measurements, I like to say, okay, I'm working through these 20 claims before I get up and go to lunch. And so I'm doing this. I only have 10 minutes. How fast can I pump through those 20 claims? So that also helps when you look at, you have those different dashboards and metrics that you as an employee have to meet, then everybody gets a chance to decide, okay, how am I going to attack that specific metric?
Right. That's a great one, Darla. Definitely. And the last one that we have is train not only your frontline staff, but if you're putting together new workflows, really reinforce those with everybody, with your frontline staff. And I mean, not just frontline staff in the revenue cycle management department, but frontline to your lab. So often, we have folks in intake or client services, whatever it is that your lab titles that position. And they have no idea. They don't even know what to look for. They just take whatever they receive and, put it in a file, right? To have it sent on through the system. I think the more we train and we retrain and we continuing to train, the better we're all going to be. And I know for myself, I deal with payers and medical policy every day. And I've been doing this for 35 years. You would think I'd learned a thing or two, but every time I go in and I look at a policy, I'm not going to lie to you, I learn a little something different. Part of it is because those stinking payers are always changing the rules, and the only way you find out is if you actually get in there and you're looking at it. But the other thing is, especially if I'm having dialogue with someone else, again, other people zero in on things that you may not zero in on. So continuous reinforcement and training, very, very important.
Agree. And I have to plug Telcor here because when you talk about the policy changes for a payer, you want to make sure that you have a solution that is able to support those effective dates and discontinue dates for those specific guidelines.
Exactly. Common pitfalls. Now, these are common pitfalls of a gap analysis process. So the first one is kind of funny. I like the terminology, scope creep. So we talked about on Tuesday, remember our little circle of all of our processes. And we kind of talked about then, keep it simple. And once you start your gap analysis process, have a statement of work for that gap analysis. Because oftentimes, as you're going through it, folks identify other things and they want to add to your gap analysis. And they could continue to add to so much that it is so broad that you lose the focus of what you originally were wanting to look for, right? What your original target was. So make sure that you are very specific. And if folks come to you and say, "Oh my God, that's great, but did you look at this, or can we do this?" Have them define a separate scope of work. That can be a separate project that you can also use the same wheel for, right? Use the same steps and use separate measurements for. But this is so that you can, again, keep it simple, but you're also protecting your team, right? Because I can tell you, I've been on these committees before. It's very frustrating when you are focused and then you have people coming in and wanting to continue to give you more things to do, and you can't ever get finished the original task that you were given. So scope creep, that's a new one for you. Common pitfalls. Woo! It's almost the end of the week. Ignoring front end errors. We have talked about this and talked about it. That information that we get in on the front end is crucial. It's crucial, and we have ordering clinicians that use, not only if they're still using hard copy, outdated requisitions. I've even had situations where we had requisitions for different departments in the hospital, depending on the type of testing, because we were broad scope lab. And we had doctors taking requisitions from one department to the next department. right? And they were not even applicable. And we couldn't figure out why things weren't matching up in our system. And we were able to go back and we actually had someone that rode with the sales rep and followed her around and that picked up on it, realized that that's what was happening. And so front end errors, they drive everything. You know, it's like Darla's car, right? Definitely. Okay, root cause diagnosis. Sometimes, you know, especially if you're under a time crunch pressure, sometimes you can kind of take not exactly a thorough deep dive into your root cause analysis. Sometimes folks will just say, "Oh, well, I know what that is. You know, I know what's causing that. I know what that is." And they jump to conclusions based on past data or past experiences. And when you try to make those changes based on that information, you see no improvement. And it's because what you thought the problem wasn't really the problem. I'm going to give you an example. I have a customer right now that I'm working with, and they're under that big bad A word, the audits. And, you know, they came to me and said, "We need help. This is medical necessity. We need your help to review these. We believe that we've met medical necessity, da 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 da." Well, I start looking and reading the communication from the payer, and I start looking at their notes and different things. And I go back and I read the communication from the payer again and what the audit results were, because they'd already gotten the results of the first audit and we were looking at recoupment at this point. And I'm like, I don't think medical necessity is your problem. I think they're questioning your coding and your MUEs, the units, because when you look at these codes, this code with the way you're doing your testing, you shouldn't have 13 units with that. You know, it's a panel code. It should have a 1, you know, and so we dug into that instead. So that to me is a perfect example because nobody else on the team picked up on what they were saying about coding. No follow-up or governance after implementation. How many times does this happen, right? We are so busy and we finish a process, we write the new policy, we educate on the new policy, we teach folks about what the new flow is, and then we've got a million things on our plate. So we go on to the next problem, right? The next project that we're given to do and never follow up. Only to find out in 6 months, guess what? Half of the team implemented the new policy. The other half wasn't there that day for the in-service, and they didn't go back and read the notes or ask anybody. So they didn't implement. So that wonderful gap analysis that you did and the new processes that you identified to put in place only was working 50% of the time because only 50% of the people were doing it. So again, this is another great area where your dashboard of your KPIs comes into play, because I can tell you, when I was working in the lab and when I do projects now where I'm actually, you know, covering a position in a lab for someone, I look at the dashboard every day. There are just key things on that dashboard that I think is important. I want to know what my DSO is. I want to know, you know, what my AR is. I want to know my time by certain payers of getting paid. And I also want to look at my appeals, and I want to look at, you know, depending on the testing that I'm doing or that the lab is doing, I want to look at key payers and the way that they're denying, because just of experience, it just comes from that 35 years of experience. There are certain ones that I know they're going to deny on the first round every single time, and you can send in the exact same information that you sent on your first pass. You can send it in on your repeal and they act like they never even saw it. And I think it's because they never even looked at it, if you want to know the truth. I think it's just part of their process. So definitely you've got to have your ongoing follow-up after implementation to continue that measurement. So a lab specific case study. This is one of those that shall always remain anonymous examples. But we did a gap analysis and we found that what we thought were clean claims, 40% of those claims going out had errors. They were set up for failure from the get-go. They were not going to make it. Some of them weren't even going to make it through front-end edits. And our AR, as you can imagine, of over 90 days was at 30%. Kind of makes sense, right? If 40% of your claims weren't complete and clean, that you would have an AR of 30%. So we did our gap analysis, right? And we implemented some automation. We did some more staff training. We actually changed some people around. And what we found out after the intervention, we went back to measure, our denial rate had dropped by 30%. So it was kind of in that acceptable range at that point, right? You expect that certain amount of your claims are going to get denied on the first pass. And on our first pass claims, 25% more of those were paying on the first pass. That's huge. That's money in the bank, right? And then our net revenue as a result increased by 15%. In the RCM world, when we're dealing with high dollar claims, although those percentages don't look significant, when you equate those to dollars, they are very, very, very significant. So it's always good to see positive outcomes. And I, again, share those positive outcomes because everybody needs positive feedback. So on to governance and sustainability. I know that you're probably tired of hearing the word dashboard, but we're going to say it again. Have a certain cadence of expectation with your team that they're monitoring your dashboard for, at the very least, your monthly KPIs, and then quarterly do a deep dive, do a much deeper dive. So important. And it will help you identify some challenges before they get to be huge challenges. And it also helps you identify, as Darla had mentioned, folks that might need just a little bit more training. We have folks sometimes that, we either have those folks that are easy to say, I don't know, I don't understand. I don't understand. I don't understand. But then you have other folks, especially folks that are very quiet and reserved, they'll never tell you that, right? Because they get embarrassed. So this is a good way of keeping an eye on that. That leads to number 2, continuous staff training and compliance audits. Compliance is huge. And I think it's good that you have a compliance policy and procedure and that you have a compliance committee, that you do audits and that you have them reviewed with the committee that you're looking at. And once a year, it's really good to have someone that is not in RCM actually do the audit, to do your compliance audit, because again, they will see some things sometimes that we don't see. And the last one is annual, I'm so sorry. There we go. Annual gap refresh. There was a message in front of it. Relook at your gap assessment, at your gap analysis, and if needed, re-benchmark, because you may have fixed one area, but it might show you that you have an area maybe more downstream. You might have fixed the front end situation, but you might have identified that you have, another area where you need to add automation in. And again, you get that continuous quality improvement and increased revenue. So next steps, get your pencil sharpened, get your computers charged, and kick off. Kick off with data collection. If you don't feel comfortable, or if you have a new system that you're not quite sure how to pull the data, call someone like Darla they can help you with that. Reach out to me. I will be glad to help you with that, so that, because I'm a data girl and I love data. I love to dig into it. And because it reveals a lot of things to me, I think it's real easy for folks at a higher level sometimes to make judgment calls when I zero in on my data and I can show that that is absolutely not the case. Or maybe it is the case, and this is where we think the problems are. Look for a quick win for your first gap analysis, right? Focus on something that really will make a difference. I would say look at that front end. Look at eligibility and benefit checks. Look at your prior auth. How many of your orders are coming in with prior auth? How many once you guys request? Are you successful gathering? That is a great data point right there. Because if you're not successful and your reason is because you're not getting medical necessity information that actually supports it, then you need to go back and do some education with your ordering clinicians and your sales team. Pilot your suggestions or what your findings are, and then review in 3 months, review in 6 months. See how you're doing. If you're continuing, if it seems like you've gotten that area, working really, really, really well, and everybody's on board, expand. Maybe go and expand into something a little deeper or in a different area. And then again, governance plan implementation. I can tell you one of the best tools is to make sure that you have senior leadership buy-in and support. I can't tell you how many times, both when I've worked for a lab as well as when I've been consulting, that I've been confronted with, well, that's the way we've always done it. You don't really understand, do you? Honey, you've not worked here long, have you? And the truth of the matter is, no, maybe you haven't worked there long, but you've looked at your data, you've done your gap analysis, you've reviewed that with senior leadership, and you reviewed what your suggestions are for improvement, and you have their buy-in, right? Super, super important, super important.
All righty. Thank you, Sandra, for once again sharing your expertise and walking us through the tools, tips, and real-world strategies for performing an effective RCM gap analysis. Your insights on governance and sustainability are especially valuable as laboratories look to turn analysis into lasting results. And thank you to everyone who joined us, not only today, but throughout this two-part series. We hope you're leaving with practical ways to identify gaps, apply actionable solutions, and ultimately strengthen your revenue cycle performance. If you'd like to continue the conversation, don't hesitate to reach out. We're always here as a resource. And so with that, I'll go ahead and turn it back over to Karis.
Yeah, you guys did a great job. It was so much good information. I want to circle back from Tuesday's webinar and just a couple of those questions that came in from there that we didn't have a chance to get to. So can you guys provide any tips or tricks on prepayment reviews?
Yeah, every time we think that we don't have to deal with prepayment reviews, we have our payers that change course on us. For instance, I don't know if folks that deal with United saw the United bulletins earlier this month. United had been saying that they were going to lower prior authorizations, that there was like 500 services that they were not going to request prior authorizations. Well, in their reimbursement policy updates of this month's bulletin, they're moving them all to prepayment review. So, it happens more than I think folks who don't do our jobs realize. I think it starts in the information that's gathered, right? The information that's sent in from that ordering clinician, and then also the information that you have access to from the lab report, right? Of what actually the findings were. Because, I think what they really want, I can tell you this from working at the payer, they want to know what's going on with that patient, right? Why is that doctor ordered this test? How's the doctor going to utilize the information that your lab is providing them to treat that patient, right? What are they going to do with it? So it's really that information that you have. The other thing that I think super important is, again, this is where you team with your market access person. Stay in touch with that payer. Some payers will accept your documentation electronically. Some of them still will not. So that is super important, because sometimes you think your information, they may say on their website that you can attach it electronically through Availity. Well, guess what? They're not accepting it. And the only way that you find out is when you pick up the phone and you actually call somebody. And if that becomes an ongoing problem, then work with your market access people. It may be that, there's a glitch in that system that really needs attention to be fixed, and it's not getting the attention of the payer.
Okay, great. Thank you. Another one that came in is when it comes to all the different coding strategies and the variations between HCPCS, CPT, Z code, PLA, does it really depend on the specific insurance and what they want to see and what they'll accept?
It's a combination, right? It's a combination of things. And that's why having a good revenue cycle management system that has automation built into it will be your best friend, because you do have, we have rules from CPT, right? We're challenged to code to the highest level of specificity. And, as coders, you do the best you can with that. I think it's good that if you don't have a certified coder on your team, that you have a certified coder review your coding at least once a year to make sure that you are following CPT. But then you go to payer rules, right? And they're all different. They're all different. So for instance, we started with the MOLDEX program with Medicare, with having to have Z code identifiers, right? Those Z code identifiers that identify the lab, the testing that's being done, and the technology platform. Well, now we have United Healthcare that has implemented that process. We have Humana that has implemented that process, Blue Cross of North Carolina, and a few other small payers. So that's another partnering with your market access person, making sure that if you don't have someone on your team that is keeping up with those payer bulletins, I sign up for every list serve that I see. And I pull them up when they come in while I'm having coffee in the morning, and I just scan them to see, oh, that's not about me this time, that's surgery. So we just don't worry about that. But I'll zero in, and sure enough, if it's something to do with the lab world, then I zero in on it and I really look, and then I go back and look at what the current policy is so that I can see, where is it changing? What's going on? Is it significant? Do I need to let my customers know about that? And then you go on to the other level, which are hopefully those things that are automated, like your NCCI edits. Some codes can't be billed together. Some codes are part of a greater code, right? And then you've got your panel codes that cannot be unbundled. Code stacking went away, supposed to have gone away around 2012, 2013. And we still have people wanting to code stack. And I can tell you that gets the attention. Using a lot of 59 modifiers and code stacking will get the attention for audit every single time. So it's really a combination.
All right, Darla, anything to add on that one?
Well, I just know that I saw a question pop up that asked specifically about the CCI column 1, column 2 edits, and wanting to know if your position on whether payers would be willing to accept those two tests together, or do we need to stick to the CCI column 1, column 2 edit and basically no bill that second charge?
I can tell you that all of the NCCI guidelines and the CCI edits that are put in place, the payers have them hard-coded in. All of those files from CMS, whether it's the clinical lab fee schedule, the physician fee schedule, the edits that are established, the new annual updates on ICD-10 codes, the mid-year updates on CPT and ICD-10 codes, all of those files, commercial payers pay license to the federal government. And those files are then hard coded into their system.
Yep, I agree. And the CCI column 1, column 2 is basically that file will let you know if a modifier is supported. So it would have that indicator that, yes, you could add a modifier if it's appropriate. If it's not appropriate for a modifier to be added, then that column 2 procedure theoretically should be no build.
Yeah.
Right.
So there's a couple other questions that are very specific to some coding and some CPT codes. We're going to take those offline and have those guys have Sandra and Darla reach out to that person specifically because they were very specific to them. So before we close out, just 2 more questions. How can we find a list of benchmarks for molecular testing?
For the KPIs, for KPIs, yeah, what I would do is you can always look on the medical group management site for those, but also network. You know, networking with your peers, you'll find out tricks and you'll find out information that you haven't been able to find on a payer website. Excuse me, or that isn't truly communicated clearly from a payer when they're asking you for more information or whatever. So I do that. I also look at history. I look at history of, what was the year before's historic data when I'm trying to set benchmarks. And then I think there are certain things that, that really don't change between the type of test that you're doing. Your DSO, your data service, how fast you get claims out, the timeliness of your appeals once you get the response from the payer, those kinds of things, they're not going to change by test to test or technology to technology. Where I think you do see changes for molecular is the prepayment edits and then the medical necessity information requests on the back end. And those, they do take time. And if you go into the payers and you look at the reimbursement policies for the payers, they actually give you a schedule. Just like with CMS, there's a reason why you got 30 days for this and you got 60 days for this and you've got another 30 days once you've done this communication. You can get that cadence from the payer. That'll also help you with that benchmark.
Yeah, and the molecular testing, I would definitely be engaging with my payers. They need to know what the test is, what the benefits are, how the patients and the providers are utilizing that information in the patient care. So always first stop with molecular testing.
Yeah, 100%.
All right. And then the last question to wrap us up for today is tips and tricks for auto posting and ERA posting, as well as automating appeals process. I feel like there's a whole bunch in that one little question.
Wow.
I'll answer that one. I'll answer that one.
Go for it, Darla.
Reach out to Telcor RCM. That's the way the system is built. All fully automated, our ERA processing, fully automated appeals process. Give me a call. We'll talk.
There you go. There you go.
All right. I'm going to ask just one really quick, and I feel like this is a question kind of based on some of my past experiences. When do you start a gap analysis? Like, when do you actually realize you have a problem and should figure this out if you really think everything's rolling, but you really don't even know what you're missing out on? I mean, is it something that should be done annually, every 5 years? Like, how do you get started?
I think, I'm going to say I'm a data girl. So I'm always looking at data. The other thing that I am an advocate of are those KPI dashboards that I review. And when I start seeing trends, if you start seeing any kind of trend, that is a perfect time to do a gap analysis. If I were a new employee as a RCM manager or director, and I was new to an organization, I would do a gap analysis at that point because I'd look at the policies, look at what really is happening, sit with my people to really see what are they doing, because oftentimes policies over here, what's actually being executed is way over here someplace, right? So that'll help you get set some benchmarks as well, so you'll know where you're at, but you can also find out what gaps are there that you can target to work on. Unfortunately, Karis, what I see from most labs is they wait until it's crisis point. They wait until they've gotten a huge audit, or they wait until the CFO comes down and lets you know how much in the red you are and for how long, and all that horrible stuff happens. I think there are things you can do, so that hopefully it doesn't happen that bad.